and gentlemen, it is such an honor and privilege to be with you transatlantically, transpacifically, wherever we are, peri-pandemic, to talk to you about the problem that we all care about. And maybe we, after this session will care. And by the way, I know people say this, but we mean it. We give away all of our slides. If you want any, just email me or tweet at me or whatever you have. We just ask you to take them, copy them, and make them better. And this is the topic of what we're going to be speaking about today in our very, very brief time together. And we can develop it even more in the question and answer period. But we're not going to be talking about wound healing. Rather, we're going to be talking about what happens in between wound healing. So let's get going. So this is what I do. I'm a foot doctor. I am a toe mechanic, if you will. And you know, I can't think of anything. What I'll tell you is I can think of two great gifts of being a toe mechanic, and the first is this: is that I can't think of anything that's more of an expression of humility in this era of rampant hubris than looking after someone's feet. And it transcends borders, it transcends religions, even I think transcends time. But it's really this great expression of humility. And the other great gift is being at the end of the body, at this anatomic peninsula. Being at this anatomic peninsula, it gives us this great gift of perspective. And we can hang out there at the end of the anatomic peninsula, and life can be relaxing, maybe even a little boring, or we can choose to collaborate with the anatomic mainland. And we personally choose to do, I think, the latter, and it's been quite exciting. But those are the two great gifts of doing what we do and what we do collectively, kind of in the field, not only of tissue repair and wound healing, but rather limb preservation. And speaking of limb preservation, this is the first surgery ever caught on video. This is the great Professor von Bergmann, who actually has a clinic now in Potsdam, or named after him. But here he is doing a below-knee amputation. And, you know, other than the fact that this procedure went by so quickly, what can we really learn from it? And it's not that he wasn't wearing gloves or didn't believe in masks or whatever, although all of that's kind of humorous. But it's really the fact that this person that's not on the screen, to the right of the video, the nameless person, he or she that's having his or her leg off 119 years ago, probably had a better outlook on life in terms of quality adjusted years left in front of him or her than someone right now having his or her leg off. And that stinks. And I think we can do a lot about it, which is why we come together in symposia like this, to commiserate, but also to maybe share ideas and data and come away with somewhere we can help people move through the world a little better. Unfortunately, right now, the truth hurts when it comes to the diabetic foot. What we believe and what we know really is that it's complicated, it's common, it's costly. Let's go through a couple of these bits of data to show what we're talking about. First of all, how common is this? Well, if we look at the overarching data from the World Health Organization's Global Burden of Disease, and these are data that we looked at a few years ago, and we revisited. I'll show you that in a minute. we really couldn't believe this when we first saw it. And I just want you to look at this, because the bottom line is when we disaggregated the lower extremity complications of diabetes from diabetes itself, we were so surprised to find that diabetic foot complications, lower extremity complications of diabetes, were a top 10 condition in terms of years lived with disability based on the World Health Organization's global burden of disease. Let's continue with that in the next slide. And if we look here, what we see is, as we look at the same data across the world, in terms of these years lived with disability for lower extremity complications are increasing for every age group in every part of the world. That's a lot of every. So this is a common and complicated condition. And I think it starts to make us think that maybe time is of the essence and maybe seconds count. But what do I mean by that? Well, every 1.2 seconds now, someone around the world develops a diabetic foot ulcer. About half the time, those diabetic foot ulcers get infected or they'll require some sort of antimicrobial. And every 20 seconds, someone around the world has part of their foot or leg off. And what we'd like to say is that time's up. And I think collectively as a family, we can eliminate preventable amputations over the next generation if we work together. But first, we got to look at the bad before we look at the good. So let's do that a little bit, and let's talk about the good at the very end and open the way for the next great lectures. Present company excluded, of course. So no one likes to talk about cancer. God knows we've all had family members that have succumbed or survived or are living with cancer. But let's do this as an academic exercise together. Some of you know this discussion and kind of exercise, but do it together as a family, because very few people outside of who are watching right now really care much about diabetes, and even fewer care about feet. But let's put these things together. What are we talking about? Well, first, let's look at this. Right now, remarkably, and these are data from Neil Barshis and our group. We didn't believe these data when we first looked at them, but we believe them now because they've been repeated now in a number of other studies. But right now in the United States, lower extremity complications of diabetes are more expensive than the 5 most expensive cancers in the US. And it's unbelievable, really, but there you have it. And these data have been capitulated, and these are conservative numbers. They've been repeated in other areas like in Health Canada and in the National Health Service. So there you have it. Let's continue this kind of cancer comparison in the next slide. Because if we look here, what we see is that 5-year mortality, I think, for the problems that we see collectively as a family, are at least as bad as a bad form of cancer. These are the most recent data taken just a couple of months ago, and it repeats a very, very frequently cited manuscript we published about 12 years ago. And the data are even more sobering now than they used to be. But the big idea here is that we would never think of withholding therapy on someone with colon cancer or lung cancer or breast cancer, but it happens all the time with diabetes complications. People just say, well, that person has a problem, they're going to get another one. Why not just cut the foot off and be done with it? And for some patients, that's probably the best therapy. But I think we can agree, probably not for most. And that's what we're discussing right now. That's why we continue this discussion and have these theoretical arguments so we can have actual discussions with our patients at the bedside. And that's what we're going to talk about now, right after this. So let's continue this sort of cancer cavalcade. Before we get to anything feel good, and let's talk about not only diabetic foot ulcers, but their recurrence. And a couple of years ago, we did a technical review where we looked at the best available evidence, not only at tissue repair and wound healing in the diabetic foot, but really at their recurrence. And this was the very first paper to do that in a kind of big scale. So let's look at that. So check this out. With the best available data we have, folks after healing a diabetic foot ulcer will have a recurrent wound somewhere on their extremities. At about 40% will have a recurrence at 1 year, about 2/3, give or take it, at 3 years, and 3/4 at 5. So what we have to ask ourselves is, can we really heal anyone? Or is it just the height of hubris to think that we can do that? Or are what we really are doing, should we reconfigure how we think about this? Because recurrence, ladies and gentlemen, is not only common in this population. Recurrence is likely. So if the foot in diabetes is a little bit like cancer, and we've talked about it with its cost, its complications, its morbidity, its mortality, as it were. When people then maybe when people are healed, maybe they're not healed, maybe they're in remission. And while this seems like just a turn of phrase, I assure you that it is not. Sometimes words don't matter, but other times words do matter. And what do I mean by that? Well, let me just offer you this tip. We've been using this now for many years with our patients when we talk to them, and we'll say, Mr. Jones, Ms. Garcia, thank God you're healed. And when we use the word healed, we see them kind of relax a little bit because they've just ticked something off their checklist. They're healed. And we say, but you know what? This problem is just like cancer. And then you say the C word, and then you see them stiffen up, and you see their significant other in the corner of the room, or their granddaughter or whoever it is in the corner stiffen up. And you say, just like cancer, you know, and we've talked about this, Ms. Garcia, this can shorten your life. And just like cancer, when you're healed, you're not healed. You are in remission. And then you see them kind of cock their head and look at you. What do you mean? And you can say, look, in our long life together, it is almost a certainty that you're going to develop another wound. But our goal is to make that wound as unusual and as uncomplicated as possible. And here's what we're going to do. And as you tell them this, we're going to get you in the right shoes. If we need to operate on you to change the way your foot hits the ground, we're going to do that. But we're going to get you a brace if you need that. If you have, and when they start to hear some solutions based on this, they start to relax just a little bit. And that is just an important tip. That's an important tip that I'd give you. But what's cool is now entire nations, entire health ministries have been adopting this. This is from Scotland and the National Health Service there. And they have now adopted the idea of stratifying people based on risk, and their highest risk is in remission. And you see percentage prevalence of this, and you can apply appropriate key figures to that, but also resources to that. And briefly, let's just talk about recurrence here in a slightly different way. And if you look here, these are the three most common things associated with recurrence. And what's the middle one? It's this pre-ulcerative lesion. What does that even mean? Well, it's this. It's a callus. And how do you explain a callus to someone? Well, this is a common event that's going to cast its shadow before. And if we're comparing a callus to cancer, a breast, then it would be like, because this is a coming event. Both are potential coming events that cast their shadows before. And so ultimately, how do we prevent, if we can't prevent all recurrence, how do we prevent severe recurrence? Well, now we have all of these tools at play, and we're going to talk about many of these maybe in future meetings, from thermometry to appropriate shoes, to smart socks, to appropriate rehab strategies. All of these things are now very, very real, and there's a very, very good news on the horizon for caring for these patients. And this is an area where we have been focusing heavily. In conclusion, ladies and gentlemen, let me just show you this little video here because it reminds me of my days as a goalkeeper. So back in the day, I was a goalkeeper all the way through university, and I still feel like one in clinic. And when I saw this video, it made me crack up. And when I got myself off the floor cracking up, I said, man, that feels like me, not in the goal, but in clinic, you know, looking dumb, but somehow like in position, even though I'm looking dumb, to save, make a little save here and there. And it made me think of this great quote from the great Mason Cooley, who said back in the day, if you position yourself well enough, circumstances will do the rest. And you know what? I believe that. And I believe that's why we come together in meetings like this. And if we position ourselves well enough, maybe we can make a difference and keep a few more legs on a few more bodies, and that, and our patients can lead a higher, not only lifespan, but a better health span. Because I think that's what we all deserve, no matter what our health and no matter what our age.